Good afternoon, everyone. Before I start, I'd like to disclose the fact that I'm the founder of a consulting company based in what we call the Swiss Silicon Valley, and where we focus on digital innovations with medical applications. So I don't know if you have seen this recent paper published in The Lancet. That's pretty impressive. They claim that 4.2 million people die worldwide within 30 days of surgery, and that this is actually the third leading cause of death on the planet. And we know from another Lancet article that most patients who die after a surgery are not admitted to critical care at any stage. They basically die on the wards. They die on the wards where nurses are doing spot check, usually every 4 to 6 hours. And because of the intermittent nature of this spot check, they miss some adverse events. And we now have studies showing or quantifying how much we miss just because we don't monitor these patients continuously. So this is the first illustration. It's a study published a few years ago by the team of Dan Sessler from the Cleveland Clinic, showing that when nurses are doing spot check every 4 hours, they miss around 90% of hypoxemic events, defined by a SpO2 below 90% for at least 1 hour. This is a more recent paper. It was published just a few weeks ago in Anesthesiology. They also miss 50% of hypotensive events, just because they measure the blood pressure with the brachial cuff every 4 hours. So clearly we need solutions to improve the way we detect clinical deterioration on the wards. And one of these solutions could be the introduction of continuous monitoring. This is a cartoon recently published by Ashish Khanna, and I think it's a very nice illustration of the situation today. You see a patient who is deteriorating in the middle of the night at 4:40, and then at 6, we realize that something is going wrong and then start to initiate interventions. And then you have what could become standard of care in the future on the wards, a patient monitored continuously, deteriorating again at 4:40, but at 4:42 we are aware, and so at 4:45 we can start therapy. So then from this very simple cartoon and concept, we can imagine multiple benefits, clinical benefits. Because of the earlier intervention, we can expect a better outcome, a decrease in the number of rapid response team calls, a decrease in cardiac arrest, a decrease in mortality, a decrease in ICU transfer. If we can detect clinical deterioration at a very early stage, we can probably prevent many ICU admissions, a decrease in hospital length of stay, and even a decrease in cost. So is it a dream? I don't think so. We actually already have some evidence supporting the notion that continuous monitoring on the wards is useful to improve outcome. Studies so far have been done with wired systems, classical monitoring systems. And here you have an example of a classical pulse oximetry system giving continuously pulse rate and SpO2, but what's interesting is that the information is sent immediately and automatically to the pager of the nurse in case of deterioration. So this system was used in this study by the group of Andreas Tenzer in this article published a few years ago, actually more than a few years ago. You see it was published in 2010 in Anesthesiology. So they monitored a large number of orthopedic patients, most of them receiving opioids. And in the unit where they did implement this monitoring system, which is visible on the left-hand side of the slide, they reported a significant decrease in the number of rescue events as compared to what happened in the two control units, Unit 1 and Unit 2. It was associated with a significant decrease in the number of ICU transfer. We can imagine as well to use bed sensors. This is an example of a sensor. It's a piezoelectric sensor. You can live under the mattress, and it's going to detect the heart rate and the respiratory rate automatically and continuously. This system was used in this study published a few years ago in the American Journal of Medicine. So it's a contact-free sensor. They studied a large number of patients, and they reported a significant decrease in the number of calls for cardiac arrest that was associated with a decrease in ICU and hospital length of stay. So once again, a study suggesting that as soon as we monitor continuously patients on the wards, we're able to improve outcome. In the future, we could even envision to use video monitoring to detect heart rate, respiratory rate, and maybe more. There are actually a few technologies under development. Having said that, I'm not aware of any validation study published so far, but it's coming. The thing is that I'm not sure actually we need this kind of video monitoring tools, because what's really key is to be able to monitor ambulatory patients. You all know that early mobilization is a key element of enhanced recovery programs. So we want to be able to monitor patients also when they leave their bed or they leave their room for physiotherapy. So this is an example of a system where you see a wireless brachial cuff. You have a patch on the abdomen to monitor respiratory rate. And then you have a pulse oximeter on the finger with a small connected to a small wrist unit to monitor pulse rate and SpO2. So all these variables are monitored and the information sent wirelessly to a central station. This is a study assessing the impact of using these kind of technologies on outcome. Again, a large study over 2,000 world patients, and they reported a significant decrease in cardiac arrest and mortality. And the good news is that there are more and more solutions coming to market. In this paper published 2 years ago, we actually reported 6 different techniques. You see 4 adhesive patches and 2 necklaces designed to monitor vital signs on the wards. And that's a more recent editorial I published with Dan Sessler, where we found actually at least 11 adhesive patches. So today it's probably more, and tomorrow it's going to be even more. Adhesive patches are probably the tools we need. I said we need monitoring system working in ambulatory patients, and there are already surveys showing that the patch is found very comfortable by patients. And of course, but then it's not specific to the patch, they actually feel safer wearing the patch. But clearly there are challenges ahead. One of them is accuracy. We have to be sure that these new tools are accurate, meaning they really measure what they are supposed to measure. And there are very few validation studies published so far. That's an example of one of these validation studies done by the group of Kork-Kalkman. They assessed the accuracy of this patch to measure heart rate and respiratory rate. And you see on the left-hand side, that's pretty accurate to measure heart rate, but on the right-hand side, it's disappointing with regard to respiratory rate measurements. And we cannot continue to neglect respiratory rate because it's a very important vital sign. I don't know if you have seen this paper published already a few years ago in Critical Care Medicine by the team of Dan Edelson, a very large number of patients, and they tried to find what are the best predictors of clinical deterioration. And by clinical deterioration, they meant cardiac arrest, ICU transfer, or death. And when they looked at multiple variables, actually you can see respiratory rate was the best predictor of clinical deterioration, followed by heart rate and blood pressure. So if today I had to choose 3 main variables I want to focus on, that would be respiratory rate number 1, then heart rate and blood pressure. Connectivity could be a challenge as well. You understood the concept is to monitor vital signs continuously with a wearable. Then the information will be transmitted to a central station and then to a mobile device so that caretakers, caregivers can react when necessary. The thing is that we cannot rely on classical Wi-Fi connectivity systems because of the high power consumption. Would not be an issue between the central station and your cell phone, for example, but that's clearly a problem if you want to send the signal from the sensor itself to the central station. We also cannot reasonably imagine to use classical Bluetooth and Zigbee connectivity because of unpredictable disruption. Because when the patients are going to the bathroom, they may lose the signal. Even patients sleeping in the prone position with a patch on the chest, we may lose the signal. This is an example of these connectivity issues, which are very common when using mobile monitoring systems. It's a study done with this monitoring system. And you see that they report 16% of the time they were actually unable to get the information. And of course, as soon as you rely on these systems to monitor your patients, you need to be sure that you are not going to miss any adverse event. And you see that when they had difficulties to get the information, 17% of the time, it was actually related to connection failure. The good news is that several companies developed or are developing their own wireless protocols, and I think it's absolutely key for the future development of these monitoring systems. False alarms, you know what it is, but patients as well. I think false alarms are first of all a burden for patients, and we need to exclude alarms from the rooms. And I personally don't think it's specific to the wards. It should be the same in the ICU, but it's a different story. Alarms, we are also concerned as clinicians by alarms, and this is a concept of alarm fatigue. When there are too many, at the end of the day, we don't probably react as we should to all these alarms. And you can imagine that if tomorrow we start monitoring patients, not only in the ICU or in the PACU, but also in the wards, particularly ambulatory patients, we'll have to deal with a large number of artifacts. The good news is that we start to have very smart software able to filter artifacts. And thanks to machine learning systems, you see more and more of these studies showing that we can more accurately classify real alerts and artifacts from vital sign monitoring systems. Nurse workload, of course, we want to be sure we're not going to dramatically increase the work of the nurses. They're on the wards. They have to deal with a large number of patients at the same time. The idea is not at all to create new ICU beds on the wards. So we have to develop very simple systems able to digest the information and deliver straightforward information to the nurses. Today, they already aggregate very often vital signs together to calculate early warning scores. And actually, monitors designed to collect vital signs on the wards today are able to automatically calculate early warning scores and very often to send the information to the EMR. But tomorrow, it should be even better. Thanks to AI, we can envision very smart software able to predict very accurately clinical deterioration. And this is an example of an existing tool. This is a safety index. It's a smart fusion of heart rate, respiratory rate, SpO2, non-invasive blood pressure, and temperature. And as you understood from previous speakers, these algorithms are just not adding all these variables together. They also take into account the trends and the changes over time and the magnitude of changes and the variability and so on and so forth. There are multiple ways to describe signals from a mathematical standpoint, and they are integrated by this smart software. For us, clinicians, the bottom line is the following. We can get a better sense of who is going to deteriorate. And there are a few studies from the team of Marilyn Ravnak and Michael Pinsky showing already that this safety index, which is ranging between 0 and 5, is susceptible to help us predict cardiorespiratory instability before it happens. What's key as well, I think, is the way we deliver the information to nurses. I think it has to be not only one number, but color coding may help as well. And you see here an example with data fusion. So once again, they would see just one number between 0 and 5. And color coding, obviously, the patient is red, needs special and immediate assistance. This is another example with data fusion and trends. I think it's also very powerful. In this system, they give you a number between 0 and 100. I personally I'm not even sure we need a number. If you just look at the graph, I think it's easy to realize that the patient at the top is obviously pretty stable. Something is happening in the middle, but otherwise the patient is stable, and the patient at the bottom is unstable and clearly deteriorating at the end. And this is, for example, the dashboard a nurse working on the wards could use tomorrow. She would see the 9 patients she has to take care of. And obviously, she would know that these patients need immediate attention. On the other hand, other patients don't need to be disturbed, particularly if they are sleeping, just to measure their blood pressure or respiratory rate. So it's going to be a way not only to improve the detection of clinical deterioration in patients who are going to deteriorate, but also a way to improve patient satisfaction, for instance, to decrease sleep disorders in patients who are not developing complications. Finally, we should be monitored. I think in a perfect world, we should monitor all patients in the hospital. That's my feeling because we can already monitor a lot from home. So it would be a paradox very soon if tomorrow you go to the hospital and then no monitoring anymore, no continuous monitoring of heart rate, respiratory rate, blood pressure, and so on and so forth. But clearly we have to be realistic. It's not going to happen like that. And probably we'll need to start by stratifying, selecting patients who may really benefit or who may benefit the most from continuous monitoring. And to do so, once again, AI and predictive analytics or predictive algorithm may help us to identify who are the patients at high risk of clinical deterioration. And this is an example with the ECART score developed by the team of Dan Edelson. It's a smart fusion of age, vital signs, and lab data from the MR. And with all this information, they're able to predict clinical deterioration better than we do today with the NEWS or the MUSE, so the National Early Warning Score or the Modified Early Warning Score. And of course, much better than if we look at a single vital sign. So the concept, as you understood now, is that tomorrow, when patients will be admitted at the hospital, we will start, of course, collecting information, clinical information, biological information, images, and so on and so forth. And then this software will tell us what is the probability they deteriorate. And then we may be in a position to decide if we continue to ask the nurse to spot check every 4 hours or more often, or if we need to use a continuous monitoring system. Then, of course, I have to briefly mention the cost, because each time we bring new technologies to the market, there is a cost associated with that. But remember, I mentioned already studies showing that with these continuous monitoring systems, we should be able to decrease the number of rescue events, to decrease hospital lengths of stay and the number of ICU transfer, and even to decrease ICU lengths of stay. So there are possibly economic savings or economic benefits associated with the implementation in the future of these monitoring tools. And there are actually already a couple of studies that try to estimate what could be the economic impact. This one was published a year ago. And after the implementation of a monitoring system, for instance, it was actually the piezoelectric sensor, you live under the mattress. They reported savings ranging between $200 and $700 per patient, with an hospital break-even observed after 6 to 9 months. And this is the economic evaluation done by Andreas Tenzer. You remember this anesthesiology paper, 2010, the very first study showing that using pulse oximetry on the wards is useful to improve outcome. After a year, they looked at the economic impact, was actually a request from the hospital because they had to invest for the monitoring equipment, and they actually realized they saved $1.4 million the first year. So in conclusion, mortality within 30 days after surgery is 1,000 times higher than intraoperative mortality. So it might be time to focus on these patients as well. Postoperative complications are now recognized as the third leading cause of death. Most patients die on the wards, not in the ICU. And if you think a minute, when nurses are looking at them every 4 hours, they basically cover 2% of the time they spend in the hospital. Continuous monitoring is now possible, not only with wired system, but also with bed sensors and wearables. And I personally believe that this is probably the next major opportunity we have to improve patient safety. With that, I thank you very much for your attention.